Without further delay, I want to introduce the moderator of our panel, Gretchen Alkema. Here she is. She is the Vice President of Policy and Communications for the SCAN Foundation. And prior to joining the foundation, she was the 2008-9 John Hines Health and Aging Policy Fellow and an American Political Science Association Congressional Fellow, serving in the office of Senator Blanche Lincoln from Arkansas. Dr. Alkema collaborated with legislative staff to advise Senator Lincoln on health, aging, and mental health and long-term care policy. She also holds a PhD from USC's Davis School of Gerontology and was awarded the John A. Hartford Doctoral Fellow in Geriatric Social Work and AARP Scholars Program Award. She earned her master's degree from the University of Michigan. So I'm very honored and pleased to have Gretchen facilitate and moderate our panel.
Thank you. Wonderful. Thank you, Chris and Andy and the whole team of folks who brought this gathering together today. I'm very honored to be here to serve as the moderator, both for this panel, but also to be part of this discussion. And my boss, Bruce, who started off the day, was sorry to have to zip on out. He's got another engagement this afternoon, and then this evening it's a very full time to do. In many ways, this same kind of talk with a lot of audiences in order to ensure that we are all part of a vision and working effectively towards the implementation of a lot of new system of care models that really requires a lot of different professions to just loosen the grip a little bit about who they think they are and what they think they've been in order to transform this care delivery model that returns back to the focus of older adults and their families, in particular as the discussion for this audience. So he was certainly pleased to be here, and I'm delighted to be able to pick up the thread and move forward as we move on to an amazing panel who's a number of individuals who are going to share with us the models of care that they've been working on that really infuse the role of social work into that model to meet care delivery goals that are person-centered, that are focused on quality. I was really appreciative of the gentleman's comments earlier this morning about what is the way in which we look at quality, what are the measures that we look towards quality, and that we as social workers have to move forward towards that vision of measuring what it is that we do and being willing to be accountable for the services that we deliver. Not in an idiosyncratic way of, did we do this case management tactic, did we get these people these services, but more about what is the person's experience in those systems of care that gets them to the goals and desired outcomes that they have, and how do we as social workers facilitate that movement forward. And I think you're going to hear a fair amount of that in the kinds of talks that we're going to have this morning. I just want to give a personal note on this discussion. I have there's some familiar faces to me in this audience, and many of you that I don't know. But just to give you a background that, I live right now in very much the policy and the communications world, which for me really is just a different level of social work practice. Fundamentally, my professional roots are in social work. I went to the University of Michigan, and I'm very proud to be part of that program, which was very focused at the time, many moons ago. It was one of about 4 schools of social work in the country that focused on aging issues, which was the reason why I selected it in terms of my application choices there. And I ended up being able to work with some amazing folks in the field, Ruth Dunkel and Barrett Ingersoll Dayton and Sheila Feld and oh my gosh, there's just so many of them. Rose Gibson was one of my faculty members. So when I went to USC to do my PhD, and they said, well, I don't know if that have you done social gerontology? And I said, Rose Gibson was my faculty member. And they said, okay, well, we'll check that off. You don't have to take that class. I'm like, yeah, I think so. She wrote every book. And so to be able to have those mentors in my life at such a fundamental career stage of really stepping into the role of saying, I want to be of service to individuals, and how do I think about that in a person and context way that we do? Also in knowing very clearly that older individuals has always been my passion in life. Sorry for the moms and kids folks who have transformed and stepped over into that world, but for me, aging is everybody's business. That no matter what your background is, no matter what your life experience is or isn't, we are all moving on this trajectory of living in a world where aging is part of the equation, whether we choose to acknowledge that or not. And so to be able to have all of you together to think on this, to talk on this, and to work on this, and to really bring the values of social work into these new models of care is just really thrilling and exciting. And kind of the last thing that I'll say is, before we get to the panel, is I've been on the side of the ledger of that the medical community really just needs to better understand the social work community and the supportive services community, and that if they just knew what we delivered and knew what we were all about, they would just love us and embrace us. I still fundamentally believe that, but I would say that that's not the most successful strategy in order to partner with the healthcare system, and that's just my experience. And so I think that there are ways in which we can keep the fundamental core of who we are and what we do and what we believe and not lose any of that thread, but not walk into this discussion from a victim position of, if you just knew who we are, then you would appreciate us more. And it's like, no, 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 no. There are models of care right now on the healthcare delivery system that are fundamentally meting out punishment for health systems, that are not meeting person-centered measurable outcomes, and many of those healthcare systems haven't a clue in the world on how they were going to achieve that outcome. And the reality is that you all in this audience have the tools and the pathways and the strategies to help health systems meet their needs and to be able to raise up the value of who you are in those systems. But it takes that idea of saying, we're not a victim in this process, we're part of your solution. We've had lots of conversations with many of the health plan entities in the state that are walking forward towards the pathway of the duals integration process if the feds bless it as so. And for many of these health systems, long-term services and supports, even in the most narrow description, what it has been for them, not that they think that this is where it should be, but what it has been is the 100-day skilled nursing home visit, because that's a claims payment exercise. We know, the panel is going to share with you up here, and we all know in the audience we can do a whole lot better. And the reality is that what it is that we bring to the table is going to be a heck of a lot more cost effective than the 100-day skilled nursing home visit. And what we bring to the table is more in line with what people and families want and need, and giving that right service at the best time with the most appropriate provider is going to be the solution to addressing some of these fundamental challenges that the healthcare system is dealing with. And they have both the resources to do it and the sticks that if they don't. And so it's about stepping up to the plate and saying we have part of the solution, and a big part of the solution that's been lost many times in the health systems because they've not been forced to deal with this. They've not been forced to deal with what it means to have an individual with behavioral health problems. They have not been forced to deal with the ongoing issues of what it means to have protective services issues happening in the lobby of that hospital and not having to think beyond the walls of the curb. I mean, there's so many issues that we deal with on a daily basis, and that these programs are going to talk about that bring forth solutions for health systems that are going to be moving forward. And when you deal with older adults, it's all well and good to talk about that the supportive services model is all that they need, but the reality is that as we grow older, we have chronic health conditions and attendant functional impairment, and that means the health system is going to be involved. And as my boss said, the light is always on in that delivery system. So it's about us being good infiltrators that we are. If we really go back to Jane Addams and our social work roots, we're infiltrators and instigators, and it's about infiltrating those systems with the kinds of services and supports and know-how that we need and that we have and we can bring to the table, but also walking the walk of quality measurement and quality metrics, so it says at the end of the road, we made a difference in that process. So that's my soapbox to start us off for the late morning. And I just want to introduce to you some fantastic panelists that you're going to hear from this late morning on the kinds of models of care that get to this root of bridging medical care and supportive services for vulnerable older individuals. We're going to start off. I'm just going to introduce the whole panel very briefly, and then we're just going to kind of go down the line. We're going to start off with Martha Haas and with Jean Friedman, who are going to talk about a really creative project that they've been doing here in the broader Sacramento area that bridges adult protective services along with healthcare services within a Kaiser model. Jackie Wong is then going to talk to us about the Unlock program and the important role that social workers played in that venue. And then June Simmons, somebody that many of you know, is going to talk about what the kind of work that Partners in Care has been doing and is looking forward in doing in these new models of care. So without further ado, we're going to have our first two panelists come up and just walk us through the presentations. What I'd like to ask from all of you is at their presentation point, if you have clarifying questions about their slides or their very particular model of care, feel free to ask 1 to 2 of those. But in terms of the larger discussion and the themes across the panels, we're going to deal with that after the lunch period, and that's what we really want you to write down on your cards. So hope that gives some structure for how we're going to do this morning's session, and Martha and Jean, take it away. And be careful of these stairs.
Actually, we're going to stay up here, so I'm not going to fall down the stairs.
Even better. Good.
Good morning. Jean and I are excited to be here to talk to you about our collaborative case management program. And it's actually really exciting and somewhat reassuring, as I heard Dr. Chernoff talk about ER not being the place to do care coordination, and that we have people going home with discharge plans that aren't appropriate for them, and that are obviously going to be back in the ER and back for a hospital stay. So we'll be beginning year 7 next month with providing these services, and I'll let Jean take it away.
Good morning. I'm Jean Friedman. I am the manager for the Medical Social Work Department at Kaiser, currently Kaiser Roseville. I started out at Kaiser Sacramento. They added on Kaiser South Sacramento, and for 7 years I had Kaiser Sacramento, South Sacramento, and Roseville. It took me 14 years, and I am now just managing Roseville, and I consider that a great success. I'm very happy to be here today. It's interesting. When I was preparing for this, everybody now is focused on readmissions, and many years ago when we were doing this, the term was frequent flyers. So it's the same story, just different verbiage. We are here today to talk to you about how we got started and what we are doing. And for me, it was about 2001. I was called in to the head of our hospital and asked to be on the task force for this new, wonderful, innovative group that was starting in Sacramento, and they were going to be collaborating with all of the hospital systems in town and law enforcement and the fire department and SMUD and every possible agency that has any contact with any senior or disabled dependent adult. And would I be willing to do a 1 or 2 year project on this program? And it's 2012, and I'm still doing it. And we have made tremendous progress. We are very proud of our program. And this started out like a lot of things do. Anecdotally, I'll tell you a story. In the mid-'80s, we had a terrible situation here in Sacramento County where these 2 elderly sisters were found dead. One had been mummified, the other one was with her. Apparently, these women had some services, obviously not enough. And at that time, Sacramento County Board of Supervisors got enraged and said, we need to be doing more. We need to be protecting our seniors. We need to be protecting our dependent adults. And over the next 4 or 5 years, worked on how they wanted this to roll out. And in 2001, they actually came up with a project with goals for us to work on. And that's how this task force, this working group, this senior protection, elder protection task force started. And we started out with a group of representatives, like I said, from Kaiser, from Sutter, from UC Davis, from Catholic Healthcare West, as well as a variety, obviously Sac County APS was very much involved. They were the leaders in this. We were looking at our most vulnerable populations. We knew, again, anecdotally, things were going on that we didn't know. We kept seeing the same patients over and over and over. They were coming back to our emergency rooms. They were getting readmitted on a regular basis, sometimes 2 and 3 times a day. We all have, I'm sure, on our caseloads, those patients that call in or call 911 1 or 2 times a day. We had some that were calling 30 times a day. These people were impacting all of us, all of our services, all the hospitals, law enforcement, the fire department. All of us knew we needed to do something. So we got together, and initially I think everybody was excited by the project, everybody wanted to participate, and we started breaking off into groups based on I'm sorry, I'm losing track of where I was. We started looking at groups of areas that we could focus on, and the group that we're here to talk to you about today is the APS Case Management Program. Since Kaiser became the first hospital to actually put the money, put the funding, and participate in the program, I got to name it. And I named it the CMRT, the Case Management Response Team. With the goal, obviously, we wanted to improve the safety of the seniors in their homes. We wanted to link them to the appropriate resources. We wanted to obviously decrease the utilization in our emergency rooms and hospitals. But we really, really were focused on doing the right thing for these patients, all of us, for these people. We wanted to do the right thing for them. So we came up with a variety of different, we rewrote and we wrote, and we came up with different plans, and we finally went back to I went back to our leadership and came up with the initial proposal, and we came up with a certain amount, the criteria. Obviously, we were looking at residents of Sacramento County, 65 years or older, or dependent adults. They had to have some symptoms of either being abused or neglected. We needed them to meet the criteria for the program, to have repeated visits either to the emergency room or to the hospital. They often were people that had come into our emergency room, had been abandoned by family, or they had no one to speak for them or on their behalf. We saw a lot of substance use, a lot of alcoholism, a lot of drug usage, and a lot of noncompliance. Whether it was due to cognitive impairment or whether it was due to being stubborn, there was noncompliance. And that's how it gets labeled. It's noncompliance, which was bringing them back in. Or just in general, behaviors that were risky behaviors, people giving away their money to people on the streets. All of our referrals are based on self-neglect. The actual logistics of doing a referral for the program, in order for us to exchange information with Adult Protective Services, we have to be HIPAA compliant, obviously. So the decision was made that every person that gets referred to the program will have a self-neglect APS report made. And they all meet the criteria. I'm going to let Martha talk now.
All right. A little bit about the program parameters. I think Jean would probably say yes, that this is one of the best parts of the program, is that we have a social worker. We've designated one APS social worker that serves as the case manager and takes all the referrals for this program. They don't do anything else. None of the other hundreds of referrals that are coming in are worked by this social worker. So I think that's one of the big pieces. We have a Kaiser liaison that's dedicated to making the referrals and staffing with us during our monthly staffings. We also have a response time. Generally, we respond within 24 hours to 3 days, but I think how it really works out is that our social worker calls immediately upon getting the referral, calls the hospital liaison to say, how quickly do I need to be out there? I'm planning to come out tomorrow afternoon. Is that early enough, or do you need me out there right now? So that's a big piece. Also, they carry 25 cases, up to 25 cases at a time. Somebody had mentioned caseload this morning, and I'm not sure, I wasn't there in the beginning, how you came up with 25, but the social worker carries up to 25. Program services are provided up to 6 months usually, and I say usually, usually because Some of them are more than a year, actually, and usually those tend to be our conservatorship cases where we've filed for a conservatorship and they take a little bit longer. Obviously, if someone doesn't want the services, we're not providing them for 6 months. If they tell us to go jump in a lake, we're gone a lot quicker than that. The team members for this are the case manager, the team members that provide the direct services, case manager, which is the APS social worker, what we call here in Sacramento County a family service worker, and the public health nurse. And I think everybody, obviously with the audience today, are familiar with the public health nurse. Here in Sacramento County, a family service worker is one of the paraprofessionals that support our nurse and social worker. They go out and provide transportation. They sometimes provide emergency chore work if the person's caregiver has gone. Many times they're the ones that can establish the relationship. Sometimes the client or the patient or the person, as we've been saying, isn't bonding, shall we say, with the social worker, and a lot of times it's the family service worker that gets in the door. Very important part of the team. The referral process for this is hospital liaison calls in the report to the APS hotline. We have 2 social workers that are intake workers that are set aside to accept these calls so that they come in and they get handled right away. They're also responsible for making sure that the social worker with the program gets that referral right away so that they're able to call within 4 hours, make that call to the hospital liaison to see how quickly they need to be out there. And then this is what our APS response team does. And as I was listening this morning, I realized it's nothing new necessarily. It's not a new, brand new brain surgery program, but basically it's that the program exists, that they're providing home visits, all the team members provide those, sometimes they're jointly. They're obviously all working together to come up with the interventions and a service plan. They do a reassessment at least every 90 days, if not more frequently than that. They're facilitating coordination. The social worker does a really good job of working with the hospital and the medical providers in facilitating communication for the family. Education is a big piece of it, whether that's about illness or just following through with compliance. Jean mentioned the compliance problem. Assisting the family members in making difficult decisions, especially around placement, utilizing our resources effectively. They obviously do the conservatorship applications, complete and submit those, and linkages to community resources. They also participate in a monthly case staffing, so we have around the table the social worker, the family service worker, the nurse, as well as a hospital representative, and we go through each of the cases that the social worker has open, especially the ones where clients are having a really hard time or we've got some decompensation or breakdown within the family. And then program data. Right now, Adult Protective Services is providing quarterly reports that are really focused on the number of visits we've had with the client, the types of interventions, the linkages with community resources. I mentioned the monthly case management meetings that obviously provide some of the outcome we do in those meetings. But the last bullet is probably not what everybody here wants to hear. And with my boss in the back of the room not wanting to say, outcome data is difficult to get, but it is. It's difficult to look at the costs of how much are we saving with this program, and Jean can talk, I think, a little bit about that. The difficult piece is actually being able to take a look at, before this person came in, how many inpatient hospitalizations, how many times did they come to the emergency room, were those appropriate? And once they're in, how many times have they been back and why, and that kind of thing. And although I would like to show up at Jean's doorstep and sit down at her computer and look up each of them and look through it, that's not really a possibility. So, before we go on to just lessons learned, program funding sources, we use the Kaiser contract as a county match for state and federal funds to run the program.
And just to correct that, it's actually a memorandum of understanding. It's not a contract. It's a benefit issue with Kaiser.
Sorry.
Don't want to call it something that will create a benefit that Kaiser doesn't currently offer. You know, I think if we had to think back and look at what we would do differently, I think that the data collection piece is the piece that we would look at in a very different way, and probably not leave it up to me. I think that hospitals need to get serious about this and get real data analysts involved in the collection of the data and analyzing what it actually means. What I did when our Sacramento facility agreed to fund the program, and we haven't gone into this, the agreement is that the hospital would fund the program at $25,000 a year. And that was just for our Sacramento facility. So Sacramento County residents who qualified for the program who were actually in our Sacramento facility. Well, our South Sacramento facility decided to look at what we were doing because they could see that this was having real positive benefits. So in order for us to prove for South Sacramento that it was making a difference, there had been no data collection tool formulated. So I actually went into the electronic medical record of every one of these patients, counted up their ED visits for a year prior to being enrolled in the program, looking at a year post, and the first 3 patients paid for the program. So, and we're talking a $1,500 walk in the door of the emergency room. That's what it costs. Just that basic amount. The 3 patients paid for it.
We can also say that the social worker that is assigned to this program carries 24 cases right now, and we did recently in the last month go back and look, and only 4 of those 24 patients had come back to the emergency room, and 3 of those were cases that we've had open 17 months waiting on conservatorship. So had they been placed and had some of those issues been taken care of, they probably wouldn't have come back into the emergency room.
And the reality is these people are frail and they're sick, and they need to come in sometimes. And, you know, having to separate that out versus an inappropriate admission. I think the other thing we might look at differently, if we were reinventing things, I think we were pretty strict about criteria as far as presenting problems, and we were a little concerned about alcoholism or substance abuse being the primary issue. So if it's a problem that a person has, it's fine, but if it's the problem, that's the only reason that APS is getting involved, they were excluded from the program. I'm not sure I agree with that anymore, and it was my idea, and I'm not sure I agree with myself. I'm not sure having watched the current case manager especially, who works miracles with these people. She is truly amazing, and I do think that makes a lot of difference, but she's been amazing, and what she's been able to encourage people to do and support them to do, and with the help of the family service worker and the PHN, the word amazing is not underutilized with Kim. I think the other thing that we would want to focus a little bit more on, and I think that this is a county council decision, is maybe look at things that the county could possibly offer us that they don't now always offer, things like signing patients into skilled nursing facilities instead of going the conservatorship route, that kind of thing, just getting creative and thinking a little bit out of the box, you know, encouraging that kind of thing. The other piece is, again, it's our responsibility as far as the liaisons to keep this program at the forefront of everybody's minds. I forget, I'm busy, I've got a lot of other stuff going on, and I realize it can be weeks before we haven't made a referral, and it's like, wait a minute, we've got this fabulous program. And we have this fabulous program because, and now I'm getting calls, and I know that the county is too, from other counties, both Alameda County, Placer County. We're hearing from other counties. Everybody's looking at novel ways to approach this, and this is just one thing that we think is pretty impressive. That's my lessons, I think.
Wonderful. So at this time, any clarifying questions from the floor about the program itself? If so, please step on up to the mic that I hope is working, and I think just step a little bit back from the mic and talk into it, and we'll get you.
Question about, does Kaiser Sacramento have an intensive case managers or social workers within the hospital?
Absolutely, we do.
Okay, and then, so how is this different? What is the role of that case manager versus the role of the APS?
It's
Worker.
what's done at home. They are the eyes and ears for us at home. We don't do home visits. And we suspect, we know, I mean, our home health social workers do, our hospice social workers do. Most of these people don't qualify. This is a different kind of case management. And so we just don't, we see patients in the hospital.
So things like discharge, service discharge planner, would that be something then that would be the role of the APS worker, or would that be the role of the hospital?
Actually, there's discharge planning nurses at our hospital. Every Kaiser's a little bit different, but at Kaiser in the Sacramento area, the social workers are not primarily responsible for the discharge planning. That's nursing.
Okay.
So we work with them, and they work very much with this program too. Absolutely. And the other piece of it that I didn't mention is our physicians love this program. I get calls from doctors saying, "Can we re-enroll someone?" They've asked me to re-enroll one patient for the third time, and I had to say no. It's not making a difference. I know it's nice for the doctor, but it really isn't making enough difference. Sometimes we have to just say, it's not enough. Thanks.
Great, another clarifying question? Okay.
What was difficult? What was the most difficult thing? How did you get through it?
That'll be a Jean question, because
I'm the only one left that was around when this was initiated.
she's been around since the
You
beginning
know,
of time.
I know, I've been a social worker for 100 years. I don't remember. Deborah, you were there. What? I don't remember there being difficulties. It was, for us, it was a fabulous way to collaborate and to kind of do the thing, you know, before HIPAA, to do the things that we used to do. Actually do social work.
Yeah, and the problem is I'm Jean's age too, so my difficulty of memory. It was.
Let's not use the mic.
I think
Yeah,
we're
just
out.
shout it out,
I think the
Deb.
mic's not working.
And the systems group that Jean talked about, you know, we were all talking about the same clients in all of these meetings. And so we had a good collaboration going anyway. But the thing that really, I hate to get back to, it's the money. When Kaiser said $25,000, that was match money, right? It fully funded a social worker. Normal, the salary then was $125,000. That was inclusive of benefits also. Because of the money we pulled down, we now had a fully funded social worker that was then working on some very difficult cases that would normally have gone to the larger group of social workers in APS. So it pulled out those difficult clients for somebody to focus on. The other social workers in APS had more time to focus on the other referrals. So for $25,000, which you can correct me if I'm wrong, Jean, but for Kaiser wasn't a whole lot of money. They got a lot of bang for the buck. And part of the issues that were identified at the time was not only repeated ER admissions, but the length of stay in the hospital. Because a lot of these clients were very difficult to place. They couldn't go home. And so Kaiser was also looking at that, bed space in the hospitals. And so, you know, when everybody figured out what that $25,000 did, and that's why now we have Sutter on board, you know, more Kaisers.
And we have a contract with Sutter North, Sutter South,
Yeah,
and
so,
or I'm sorry, Sutter, Kaiser North, and Kaiser South.
but the collaboration actually, once people started talking about this, actually was pretty easy to get people to buy into this, you know, given the small amount of money we were talking about to be able to effectuate this type of change.
The opposite is actually true. I've been scared to death that the county's going to cancel the program because what benefit it is to them to get 25,000. So thank you.
Great. So at this point, we're going to move on to the next presentation. Please write down your more thematic questions and comments on the cards, and we'll collect those at a later point in time. And so, Jackie, it's all up to you.
Hi, everyone. Can you hear me in the back? Okay. So the PACE model, is obviously, operates very differently, than what Kaiser does. I just wanted to get a sense from the audience, how many of you know of what a PACE model is or have heard of Unlock? Great. I think we're doing pretty well. I've been with Unlock for 20 years. And I understand from this morning's presentation that one of the speakers has already, given a brief introduction, of PACE. So thanks for that. Unlock is the original PACE program, in the country. And over the past 40 years, this model of care has been replicated around the country. I might not have the exact number, but I believe that we have over maybe 85 PACE programs around the country. Just in California alone, there are 5 programs. Sutter is one of the PACE programs, which is in Sacramento. And in Bay Area, we have 2, and in LA and in San Diego. So today, I'm gonna, share with you how the PACE model, works, and what the social worker's role, is in the PACE, model, and how, that affect the care coordination. So Unlock actually, is a Chinese name. It means peaceful and happy place. We started 40 years ago as a small senior center in Chinatown, North Beach area. And over the years, we incorporated the medical care. We got some funding, from the state, from the federal government, and developed from a demonstration project, to a long-term care, model. So this is our mission. I'm not going to go into a lot of the detail of the history, but it's just that, over the years, we have gotten a lot of support, and we have also proven, to the state and to the federal government that this model works, and we're able to save them money, especially in terms of, placing people in nursing homes. Our mission really is to keep people, at home, and to prevent any premature institutionalization, nursing home placement, for as long as possible by providing the comprehensive care that I'm going to talk a little bit about in a few minutes. This is also the history, which I won't, go into, and this is just a map, showing how Unlock developed over the years. So PACE actually stands for Program for All-Inclusive Care for the Elders. We are very specialized, in providing care to a specific population, and we choose to do that for the frail elderly. A lot of the PACE funding, actually most of the PACE funding comes from the state and the Fed. So I'm talking about, Medicare and Medi-Cal, dollars. I believe at Unlock, we have maybe over 90% of we call our clients participants. We don't call them consumers. We don't call them, what's the other, beneficiaries. We don't call them patients. We choose to call them participants. So our participants, most of them, they are low income, they have Medi-Cal and Medicare, and that's how their services are paid for. We do have a very small percentage of participants who are private pay, those who don't have Medi-Cal or those who don't have Medi-Cal and Medicare. So we are community-based, so unlike, Kaiser, and we focus a lot on preventive, care. We are comprehensive. We're also a capitated program, which I talked about, that we receive funding from Medi-Cal, Medicare, and they actually give us a monthly per person per month payment. And we use that chunk of money to provide all the services that all the participants need. And of course, the services are coordinated. So these are the people that we serve. 55 years, actually is not considered, an elderly, in these days. But this is the guideline that, we go by.
It's looking closer every day.
But I remember a comment that I heard today that, we looked about the biological age and we looked about the chronological age. And that, yeah, we do have a lot more people, who are chronologically younger, but they exhibit, more physical or functional disabilities. And that's getting even more each day. So this is how we define frailty. Has to be dependent on 3 ADLs, have some kind of cognitive impairment, plus dependent in 1 to 2. Oh, that's a typo there. IADLs, and then we have some definition also for medical frailty. Okay, I already talked about that. So what does a typical unlock in a participant look like? And as you can see, from this slide, obviously, still, women outlive men. So most of our participants are female. And the average age is 84, so it's pretty old. And a lot of them, are dependent on 3 ADLs. And they have some kind of, cognitive impairment. The number, the 53% of cognitive impairment actually, I think, is underreported. I believe, should be like maybe around 75 or maybe going into the 80%. The average length of stay in our program is about 3 to 4 years. So when you look at that time frame, we actually, have the luxury, to really get to know our participants, and most of them, they stay with us, until they pass away. So we're like a second home, to a lot of them. In terms of ethnic, how ethnic diverse, we are about 60% Asian Pacific Islanders, about 20% Caucasian, about 12%, 15% Hispanics, and the rest African Americans, and others. And these are the most common diagnoses of our participants. And as you can see, they're pretty frail. And this is the comprehensive services, that the PACE program provides. So we operate, in different centers. It's like an adult day health model, but what's different is that, we have the medical component in it. So our physicians, our nurses, all our staff are actually, paid employees. So unlike a person who has an IHSS attendant, who needs to go out to see a physician in the community, they actually come to Unlock, to see, to receive medical care. And while they're in the day health center, they also get their socialization, they also get a hot lunch, and they also get, services from social work, and if they need rehab services, they can get the OT-PT therapy during the day. So these are the typical disciplines, within the interdisciplinary team. And how the team model works is that everybody gather around the table. It depends on, which center it is. Some centers might have a team meeting to talk about cases every single morning. Some might choose to do that like 3 times a week. And that actually, gives us an opportunity to talk face to face on, issues that participants face. and which is very different, than the fragmented, model outside in the community. So these are, some of the services that we provide when somebody comes to the center. And here are some pictures. We also have medical specialists who come on site. I know that, if you're on Medi-Cal right now, you no longer receive dental services. Am I correct with that? But in the PACE model, we still keep that. So our participants, still get their regular routine dental check. And if they need special appointments for dentures or whatnot, we'll provide that. So that makes PACE model very special. We provide home care services. So we have a crew of people, who actually go out to participants' homes to care for them, and we also have a crew of drivers. So unlike, if somebody, a client in the community, needs to go to places or go to see the doctor, that person might need to rely on paratransit. At Unlock, these services are in-house. So all we need to do is to give, transportation dispatcher a call, telling that person that, hey, Mr. Smith needs to come in tomorrow, for a dental check, and that gets done. The way that we do evaluation is that we reassess every participant on a biannual, basis, and that is done by every member on the team. And if needed, that person gets assessed, earlier. So this is the cycle, how we enroll people, assess the person, and then the whole team will get together and we develop a care plan, together, right there at the same table. And then, we deliver the services and then we reassess every 6 months. So in terms of care planning, some of the advantages of having the service providers, sitting at the table, obviously is that, we share the same goal. Everybody is employee, of the same agency, and we all have a lot of knowledge, about our participants. The social workers, we share what the other team members might not know, because we usually are the discipline, who get to know the participants, a lot better than the others. So we would use morning meeting time, to share. And I'm really grateful that I don't see, that kind of hierarchy, within Unlock, that the PCP, might always be on top, whether or not the other disciplines are just supportive, of whatever decision that the doctor makes. So I don't see that, all the years that I have worked in that agency. And that's, again, the beauty of the PACE model, that it really creates, an environment that everybody, is very respectful, of the others. And we, back to this morning talking about, person-centered, we value that a lot. So whenever we have team discussion, we would see that person, use the philosophy of person-centered, and we'll listen to every discipline's point of view, and then we'll come to a decision collaboratively. So again, I think another advantage of having everybody, on the team is that we can, modify the care plan, right there. And whatever gets modified, can be delivered, right away during the day. So let me tell you a little bit about the social work department at Unlock. We have about 22 social workers, and most of the social workers that we have are bilingual, and I think it's very important, especially in the Bay Area. So you can see all the languages, that our social workers speak. We also have supportive staff within the department to help us with, bureaucratic and clerical matters. So I know everybody in the room here is very familiar, with what a typical role, of a social worker, is. One thing that at the PACE program that, we do is that we also can be a rep payee, for some of our participants, for those who have no caregivers, for those who might have a family member who has a history of, abusing them financially, then we can apply, to be a rep payee, for this person. And then the social worker's role is to take over to be the financial manager. So it's something, again, special that we do. So in terms of, how we play a key role, in care coordination, again, a lot of the coordination, is done during the team meetings. And whenever there is a bigger team issue, like, when the level of care of a participant changes, when the participant is no longer safe, living in a community, that we might need to look at, out-of-home placement, for things like, maybe elder abuse or neglect issues, that come up. Or, when it comes to a point where we need to involve, caregiver, in making decisions, social workers really play a key role by pulling, people together. And also at PACE, talk about case management because, PACE is so rich of having, different disciplines, right there. Our disciplines, also take the responsibility of communicating, with our participants or their caregiver. About what their needs are. They don't necessarily need to go through social work to get that accomplished. So for instance, if Mr. Smith, his home care schedule is going to be changed, the home care coordinator doesn't need to go through the social worker to make the call to the participant to let him know that this is going to be changed, but that they would make that call themselves. So that would make the communication a lot more direct and efficient. But we, of course, if there is a breakdown in communication or if it's a very challenging participant, then of course the social worker will intervene. We also do a lot of care coordination beyond the team. So somebody has to enroll into the program, in order to receive benefits at PACE. So social workers work a lot, with the enrollment department. We work a lot with the marketing, department in trying to, get a participant in the door. We also work a lot with health plan, administration, dealing with Medi-Cal, Medicare issues. Because we also contract with community RCFEs and nursing homes, so sometimes we need to be pulled in to the process of selecting which home is appropriate for our participants. So the social worker would coordinate the care plan with somebody in our contract management department. And I mentioned earlier that we also help dealing with the financial management piece for our participants. And we have a separate, mental behavioral health team, at Unlock. So we have people like MFTs, psychologists, who are on the team. So they also, collaborate, very closely with the social workers in terms of, providing mental health services for our clients. So this morning I heard that somebody mentioned that it's very important to have a support system, for our clients, or for our participants, and we value that a lot, at Unlock. We know that, medical, again, is only a small portion, in looking at the holistic care, for our clients, for our participants, and we understand that, partnering with our caregivers, is also extremely important. So we wanted to make sure that, they know that we are there, for them, and that we also, seek, partnership, from them. So in order to keep our caregivers sane and preserve their, mental health, we have learned that it's very important, to offer them, not just our participants, but offer the caregivers some support. So besides providing, individual counseling, providing, support groups, we have had some very creative ideas which are coming, in the next few months. We're talking about, for instance, just some highlights of this initiative of creating a newsletter, a caregiver newsletter, that can be emailed or can be, sent by regular mail to our caregivers to share with them, what are some of the maybe, stress reduction strategies, that they can use, or to share with them or to highlight, some of the services that, Unlock provides. Similarly, one center, is going to have a caregiver day where they would invite caregivers to come in to be pampered and to also learn about, what some of the interesting, topics, that might attract them. For instance, how to make your home safer. Then we're going to collaborate with an OT, to give a talk like that, or to learn a little bit more about, what dementia is and what are the treatments out there. Then we'll collaborate with a physician on that. And then we also, participate in a lot of advanced care planning effort. So like what Jean and Martha talked about, we're very familiar with APS, so as Kaiser. So we work with outside entities, beyond what we can provide, in Unlock. Even though, PACE program is very comprehensive, but there are days that we need to, work with the outside world in order to, keep our participants, safe in the community. So these are, some of the entities, that we work with. We also work with like discharge planners. We also work with, other community agencies besides, county agencies. So that's my presentation.
So we have time for one or two clarifying questions, and if you have a loud voice, then you can go for it.
Jackie, it's very comprehensive, and you have a lot of staff. What capitated amount do you get monthly per client in order to be able to afford that?
I know a lot. I don't know exactly, what the figure is, but I know that Medi-Cal pays about 2/3, versus Medicare pays about 1/3 of the pie, and is in thousands of dollars a month per person. Per person. Mm-hmm. Yeah.
I can just say from my understanding of how PACE functions on the financing side that part of that is that's the reason why individuals have to meet the risk criteria to be able to be eligible for the program, is so that it's not a y'all come kind of exercise at PACE. It truly has to be individuals who have met that certain level of functional impairment criteria, both as well as the medical necessity and frailty index, and that ultimately, that on the Medicare side, it builds off very similar to what many Medicare Advantage plans have in terms of their rate structure, that is risk adjusted based on chronic condition load and intensity of the care that's needed. And then certainly on the Medi-Cal side, it's based a lot on the functional criteria with the goal of keeping people out of nursing homes, which is still more expensive than individuals working through the PACE program. So, but it's a lot of money to be able to pull together. Right. Well, and I think you're right. I mean, in terms of when you look at adult day health care, that's always been financed exclusively on the Medi-Cal side in terms of the consistent funding stream that didn't have the Medicare side in which to balance it, and that the idea of these integrated care models has always been that, when you save on the health side through reduction in ER and hospitalizations, you're able to utilize those dollars and bring them over to the community-based services side. And that's the challenge that adult day health care has sat in, because it didn't have both sides of the ledger upon which to pull from.
And actually,
just to add a little bit, I think the identification of what Gretchen's talking about is a frailty factor adjustment.
Right.
So if you understand that, you understand, and in addition to the ADHD services, Unlock is responsible, as is PACE, for the full continuum of care. So if you have somebody sitting in an ICU for weeks,
That's right.
PACE is responsible for that. If you have somebody that needs to go to a nursing home, PACE is responsible for that. So it's like,
It's a health
I
plan.
like to think
Full
about
boat.
it, it's the duals integration project on steroids.
That's right. That's exactly right.
And-
Thanks, Ed.
Yeah, thank you for that. And I just wanted to add that in the past 2-3 years, the state realized that, they can no longer allow, people to, enroll, and then the state will come in to certify them. So they changed the process. Right now, we have to send all the paperwork, to the state so as to get that person certified, as somebody eligible, for the program before this person can actually enroll. And they have also tightened, their criteria in terms of, eligibility, and they looked at it, every year. And if somebody, is not eligible anymore, they have to leave the program, unfortunately, which is, something that, years ago we didn't have to face that much, or they were a little bit, loose, on those criteria.
So we have time for one more quick clarifying question before we move on in the panel. So you've got the microphone.
Okay, let me move back for just a minute. It seemed like many of the criteria for the Kaiser Sacramento County program were indicative also of mental health problems. And so I'm interested, Jackie, in what the behavioral health team does in your program, so you can convince Jean to add that in. Thank you.
A lot of our behavioral management challenges, are related to dementia, because, the likelihood of people, getting some kind of cognitive impairment, increases, with age. And as I told you that, participants who join Unlock, they tend to stay with us until the very end, when they pass away. So chances are, we're going to have a lot of, people with dementia in the program. So with that said, the chances of these people having, behavioral issues related to dementia, also increases. So we're seeing a lot of problems, for instance, of people, wandering, of people, being combative, or date night reversal. And we do have, of course, people, who have other mental health, issues. We have a big percentage of participants who are depressed, that and anxious. They have some have dual diagnosis, and we often have to rely, on the mental health specialists, to work with them. But we're not a traditional, like, how do I call it, a traditional mental health clinic where people, might go and receive a 45, therapy session. We just, I think the population that we serve, because they have, many of them have the cognitive overlay, a lot of them, they don't benefit, from that model. So a lot of the mental health services that we provide, might be just, be there with that person, and to do a lot of preventive, services, and do a lot of changes in the environment, and to educate staff, so that they know what to do in order not to have, an issue to arise.
So,
Does that make sense?
so at this juncture, we're going to go ahead and move on, and so June can have her time. And then, again, please write down on your cards, and we'll further the discussion beyond after lunch. June.
Well, very powerful examples of proven models, which I think, I'd like to look at kind of an umbrella that looks at these strong performances, which are results oriented, which are looking at measurement, but are targeting very high risk individuals, very complex circumstances that are costly, and are attempting to move money from the healthcare process to investments that improve health and quality of life, and therefore drive down healthcare costs, and therefore move the cheese, if you will. There's a lot of cheese moving in our current environment. So I think as we see the dramatic level of change that that we want to seize the moment. This is the introduction in California and some other states of the dually eligible is probably the most powerful piece tied to the Affordable Care Act, although accountable care organizations, ACOs, I think are a very similar playground wherever we can take the managed care dollar and integrate everything. So here we heard from Kaiser, here we hear from Unlock. Those are both capitated. We think then, how do we take those and how can we bring proven social work models into that health arena that so badly needs us to make that shift. Once the money moves, which it is, it looks like, then we have our day. So I want to talk then about what you've been hearing in these targeted things, that really what we're bringing is in the in-home space. It is the eyes and ears. That's the very language we've been using, so that the healthcare world is actually informed about who they're working with. It's a much broader context because health outcomes are driven not just by healthcare, they're driven by social determinants, they're driven by environmental determinants, and they're quite significantly driven by self-care or self-management lifestyle. And so I'd like to walk through some of these pieces and highlight some of the work that's been done in the MSSP as kind of a prototype, but also think about the area agencies on aging. And we have some very powerful systems in our state and in our nation that need to be redeployed to address this historic opportunity for change. And so in LA County, we've been working because, of course, we're more like a nation than a city or a county. I know the AAAs are working and the MSSPs are working on taking our models and building what we call an integrated community delivery system. We're hearing about integrated medical integrated medical delivery systems, and I think social work has the opportunity to have our day to move into that. So I'd like to kind of walk through the logic of that if I can manage to do so in the time I have. But you know, as we look at medicine, we know what they're trained to do is to look at the presenting problem. So you're hearing how these successful models move from looking at, I have an earache, my stomach hurts, I'm dizzy, I'm confused, my heart is racing, to looking at the presenting person. So it's a really fundamental paradigm shift, and we are the ones who have the ability to look at the person in their context, the biopsychosocial whole. And so as managed care moves and seeks to provide best care for best cost, as opposed to fee-for-service medicine, which seeks to provide everything they think they should as rapidly as they can in kind of a piecework basis for whoever shows up to them, for the piece of the person they're seeing. So we're shifting now to a much more holistic process. The dually eligible demonstration provides this fabulous opportunity, especially because it moves the risk for the nursing home. We have had a situation where we could care for people, but if they got worse, they could go to the nursing home and the government pays, either the person pays or the government pays. And we're moving that risk from the government to the health plan and the provider groups. So that is our day. That is the moment at which what goes on in the home determines if someone can stay there. And if we look, oh, thank you, at MSSP, for example, which maybe costs $4,000 or $5,000 a year to really engage many resources to help people remain safely at home where they prefer to be versus the nursing home, which is tenfold. Then we see in managed care the economic incentive that will accompany the moral imperative, and they should, if we do it right and we can bring ours influence to bear. that's our moment to change. That's the fulcrum for fundamental redesign. However, as we heard earlier, medicine does not really understand the social and environmental and self-care determinants of health. Medicine typically thinks that more and different medicine will solve these problems. In fact, as the duals came, we heard some of the health plans say, no problem, we'll solve that nursing home placement issue. We'll just hire 600 more nurses. Nothing against nurses. So I think we have to help articulate very strongly that a buy versus build question that's asked in medicine, that medicine should not build the solution to this. This is a situation where a new specialty is present and must be drawn on and must remain an independent specialty in a new business model, and that's us. We need to bring proven delivery systems, and we need to have the business skills to be able to really make that marriage work and rise to the challenges of the new medical, legal, financial, and information technology world we'll be faced with. But here's the motivation you can see under Medi-Cal. 70% of their budget goes to nursing home, to long-term care, I should say, which is broader than nursing home. So it's a big budget, and some of that money should come our way, and it should fund the kinds of models you're hearing about here today. It should extend the resources of the area agencies on aging. And we think that actually the MSSP is a very nice prototype. We wouldn't just like say, give everyone MSSP. We wouldn't even say, give everyone PACE. We would target tiered levels of intervention to different levels of acuity, as Ed so wisely said. So if we look at the dual eligibles, we see that they represent a huge percentage of the American healthcare dollar. Actually, in America, where healthcare is threatening our very financial viability as a nation, 5% of the population uses about 50% of the healthcare dollars. And we know we can improve on how that investment is made. So we will look a little at where are the targeted places where we can contribute. So the duals does bring all the money together, medical care, behavioral health, long-term services and supports, IHSS and the old adult health center, CBAS is going under managed care, the MSSP, and so on, the nursing home, all those are going to be under the same budget. And so we'll look at how our kinds of care can really modify quality of life, the retention of health, the slowing of the decline, the restorative resources that are available, because just because people, as they age, go down doesn't mean they have to stay down. There's a lot of resilience and restorability, and then late-stage care. So just, if you haven't seen it, I recommend you read Ed Wagner's work on the chronic care model. They say that change takes about 17 years. I don't know where we are in the 17-year cycle, but I'm thinking we're at a point where it's tipping. We're reaching a tipping point.
Right.
So this is about a 20-year-old model, and as you will see, it's a partnership between patients or people and care with the community as a whole context. So this is a very social work friendly model, and this is how we like to think about the changes we can lead now, because we can change the way services are provided. We can change the way families, neighbors, and communities support people. We can also facilitate changes in lifestyle, which is, I'm sure, what the APS model did here, is it really changes the way people handle themselves and what resources they have to do that, to get better resources. So we see that in America that we spend 4 times as much money as any other nation, yet we're ranked 27th in our outcomes. So we got to get busy, but there's plenty of money to work with. We can reduce healthcare costs if we're really, really diligent, and fund us instead, but we'll have to be highly accountable. But the reason is a lot of the money goes into acute care. And so we need to keep people out of those settings by keeping them well and giving them something other than 911 to call. We love to cut programs, but as I'm fond of saying, it's pretty hard to cut their phone. They've still got that darn phone, and so do their neighbors. So what you see is differential uses, using the dual eligibles as an example. Differential use of the ER, which we heard about, extremely expensive. $1,500 for the ER is a nice figure, but it's low. That's probably how much the ambulance costs. It's probably $3,000, and then they don't know the person, so the person gets slammed into the hospital. So we know that there's differential ER and hospital use that are extremely expensive, and so if we can, in a humanitarian and positive way, reduce those by doing the right thing, we have freed money up for the kind of things we believe in. The way we're going to need to do that, I think, is to take a lot of the proven work. There's a lot of great work in the social work and public health communities, and we need to bring them together. So the MSSP model is certainly a piece. The area agencies are certainly a piece. The new transitions work that are picking people up as they leave the hospital if they're at risk of readmission. There are evidence-based programs. We're big on the home meds program and home palliative care, which was developed with Kaiser. And there's a whole sweeping movement across the country for evidence-based self-management programs. And California is #1 in our results with that, but we are still very short of making that a utility, a readily affordable and accessible piece. Just an example of something that happens, dual eligibles illustrate, is just the inappropriate readmission rate. If someone goes into a hospital, #1, they're at risk of a hospital-acquired condition. You don't just cure, and you also get harmed in there sometimes, but also then a big risk of bouncing back in. So there are targeted populations like this that we can address. So to do this, we have to really look at the kind of targeting. You heard targeting criteria with the prior programs, looking at people. Actually, we should start with people who are okay, like us, and we should live well, stay well, and follow all the basics about achieving good health. But assuming that that doesn't work in every case, we have people with multiple complex chronic conditions, and those can still be caught early and managed. CareMore takes people with diabetes who have a foot injury, and instead of saying, go home and change your dressing and come every day and come back in 2 weeks, they drive them to the doctor's office. They debride that every day, and guess what happened to their amputation rate? It dropped by 60%. So now we have reduced suffering, and we have reduced the clog of overuse of the medical system, and we have saved a lot of money. So the multiple ER visits, post-hospital support, avoiding the nursing home, helping people not get trapped in there, and then the last year of life, which is very expensive. So using the duals as an example, quickly, we want to look at targeting. So we're going to have, wherever you are in the social work splendor, you're going to have a population that's somewhere on a continuum of health. And the intervention you're going to make, that you're going to advocate for and bring into this new delivery system is going to be tied to where people are in that system. Now, we got to have a no wrong door. We do not have a big, wide set of ADRCs in California like some states do. We have some, though, and we're trying to grow them, Aging and Disability Resource Centers. But we do have AAAs in every community, and we do have MSSPs covering most of the state. So we know that the highest costs come from these specific target groups, and that's where we want to look for a new intervention that's going to yield better health, better quality of life, and not just drive down costs, crash down costs, because we really have to do that. So we start with evidence-based self-care and targeting and screening and getting patients into services at the right moment in time, avoiding the ER. So I'm going to flip in the interest of time just to remind you we need to know what's included in long-term care. We need to know that we're focusing on issues for care coordination that we heard in PACE, ADLs, IADLs, and I only show you these not because you need them, but because when we speak to physician groups and health plans, we have to explain this. They don't think about these things, so I want to remind you that we have a very powerful voice we need to bring that articulates what it is that gets people in trouble, because we really look at those causes. And so we have to go back to basics. We have to even make the financial case. So that's why I'm bringing it to you just as a model for, because this is actually a talk we gave to the organized group of managed care physician practices in LA County, and we use this with health plans and physician practices because they need to see what's the solution. Why do they need eyes and ears in the home? And we start with things that are closer to them, like medications and chronic pain management and late-stage care in life, because those are all things where we have a powerful role, but they can recognize them because they're kind of medical. So we're going to have to start where the client is. And so you have, Bruce said we have to be bilingual to some degree. That means we have to speak medical, and we have to respond quickly, and we have to understand the legal risk mentality and the high focus on finance that's in the medical world. Since they're still bigger than we are, we're just bringing ourselves as a solution. We need to sell in a way that the customer can understand and buy. So that calls on us, I think. So care coordination really does focus on in the home. And one thing I've found is that physicians and health plans don't really understand in the home. They don't understand what that is, and when you point it out, they realize it. And so home health is just a fragment, and it's not a powerful force. So what we can bring is managing the in-home space. That's powerful expertise that we bring. And so in our case in LA County, because we are so complicated, one of the things we know is that we have to compete. This is a gold rush, and there are going to be a number of organizations that would like to run the in-home space. They're mostly large national for-profits with big information systems, a lot of capital, but not the kind of multicultural, multilingual, community-based expertise that we bring. So we felt that the health plans would only want to contract with one entity, and so to get a county-wide coverage. And so we feel as a group of cats, we have to herd ourselves into a unity, business unity of some kind, so that the MSSP providers in LA County, there are 6 of us, are working together to contract as a team. And then we're going to take MSSP, which is a complex care coordination system that both arranges and orchestrates natural resources and AAA resources and other community resources, but also has a capitated budget that's able to authorize and purchase the other missing services on a contracted basis. So we're like a mini social HMO. So that's worth having. And so we bring that to them. But we cannot only use that system if we want to catch people earlier and prevent avoidable decline. So we think we will need tiered kinds of care coordination services that can be led through a partnership of AAAs, MSSP providers, or whoever in your community is the natural leader. So with that, I think that gives you maybe a sense that we look at moving into the medical world in a powerful leadership way to articulate things they desperately need to succeed, but learning about their language, their legal issues, and finding ways to transform ourselves into the powerful tool that will really change lives and help medicine become much more what we want and need it to be. Thanks.
Wonderful. Thank you, June. I think that's a super slide actually to end on in the visual of really looking at what is the tiered roles and the trajectories based on what people's needs are presenting forward. What we're going to do now is that lunch is going to be served, and we're going to be able to stay up here as a panel. As soon as we get you all plated, we're going to start off with any clarifying questions for June, and then we're going to bring forward questions for the panel as a whole. So this is a good moment to just stand up and stretch your legs and know that we'll come back to a more robust dialogue. First of all, I'd just like to take a moment of pause and let's thank all of our presenters for really giving excellent presentations. We have really great social work leadership in the state, and much of that is demonstrated right here on this table, and with forward-thinking kind of perspectives on models of care. And so the question that came forth that was really a thought in my head to start from is, from my understanding, this is an educator's audience, whether it be formally in a university setting or folks who are in counties who are doing a lot of education and training with individuals who are coming through as interns or new staff. I mean, you really are the front lines of folks who are educating that next generation of social workers to work in really new models of care. So the question that I'm going to pose to the panel, and y'all get one thing. That's it. You can only get one response to this, because I'm sure that we could all talk kind of forever about this question. But as we look at there's pathways for disseminating these models of care, but ultimately there needs to be a workforce who has the skill base in order to be the right, I like to call it the catch for the pitch, and moving forward. And so when you think of what is the one fundamental social work skill or skill that social workers need to have to be able to be effective workers in these new models of care, what is that one thing based on the experience that you have in your program? What do we need to deliver to that next generation of social workers, either at the BSW, the MSW, at the internship level? What do they need to carry forth to be successful in these new models of care? So whoever wants to start first, but you only get one. June, you're up. I can see it.
I love the motivational interviewing, brief negotiation approach that engages people in deciding for themselves what kinds of changes in their behavior they're able or willing to make, because that's kind of universal, whether they will or won't let us in, whether they will or won't use services, whether they will or won't stop drinking or take their meds or whatever it is that they need to do. To me, that underlying skill of listening and asking and engaging is vital.
Great. Others?
Well, I was going to be a little less politically correct and say, shut up and listen.
You mean that the social workers themselves shut up?
Social workers need to shut up and listen to the silence. Pay attention to what our patients, our clients, our participants, the people that we work with are saying, sometimes when they're not talking. Pay attention to that.
Similarly, I would say it better.
More political. Shut up.
Glad that we're doing wordsmithing here on the panel as well. This is great.
So I think I would really value or have social workers really value our clients' autonomy, because in this world I think one of the big challenges even for me today is how to balance between, clients' autonomy, versus, their safety, whatever, situation they're in. And I think, for social worker, I would really recommend they have that mindset. Yeah, so.
Great.
I would say, am I on there? Yes, I would say just that for me, the use of self for social workers is really important. And I would say, hopefully, social work school, it did for me anyway, help to figure out what your passion is, to help our social work students really figure out what their passion is. I think Jean mentioned how great our social worker is with this program, and we have 3 really, really good ones that do case management, and I think it shows. You go, when you're just talking about people using themselves and being flexible and loving what they do.
I'm really heartened by the comments in regards to that these are core values of certainly what was my social work education and the ones that I know of deep, longstanding colleagues of mine. And it's probably more about the application of those principles in these new models, but fundamentally you've got to come from that place. June?
Just that we're talking about service delivery here, but I think critical skills are supervising and orienting, because I think we're going to have an army that we need, and there are going to be a lot of community health workers and other kinds of skill levels that we can prepare and supervise, oversee, and manage. And if we can then also, in addition, engage in the kind of the systems change piece that I was talking about, really getting our place at the table and holding it, that those are kind of complementary to the great work that we want to see happen. These same skills might apply, though.
Right, so that multilingual aspect is not just in terms of the negotiating with a new health system, but really being able to be a quality supervisor of a whole new host of individuals who are going to be part of these systems of care. Yeah. Great. The next question that came forth is really about, it gets down to kind of the nits and grits about measurement, but I think the overarching theme is about quality. All of us internally have a kind of a fundamental perspective of what quality is, even whether we articulate it or not. And so what I'd like for each of the 3 programs up here is to speak to, when you look at these models of care that you are bringing forward and in the process of developing and refining, what is the vision of what quality service really looks like in kind of one sentence? What does quality mean to you, and how do you think about ways to measure that? Because we are in a sense where it isn't good enough anymore to just say, oh yeah, people like it. Oh yeah, people like us, and they keep coming back. It really is. You have to be able to have some more demonstrable ways of measuring and saying definitively that whatever your quality vision is, that it's being actually executed. So, so how do you guys think about quality in your programs?
That's kind of a big question.
Yes.
But I think results orientation on whatever the measures are. I particularly liked hearing that there were dose questions, that we might not go in and stay and do everything forever with someone, but that we're looking at allocating ourselves as resources across a population, making the most strategic investments to assure people have best health possible, most independence possible, and most ability to avoid institutional care possible. So those things, based on full engagement of people in guiding their own lives, I think this would be my comment.
Which really relates back to that motivational interviewing concept of that you got to know what that thing is in order to help people realize their lives.
Right. What's the real piece that's going to twist their outcomes?
Right.
Yeah. So really titrating the interventions. But then really getting results. It's not just, I did my best.
Right.
It's somehow we actually change things in a resource sensitive way. That we don't let them take us down to such a small dose that we can't really get a result, because we heard some pretty robust interventions that were based on being able to work to conclusion. So I think certainly Unlock and PACE do that, but I thought your APS program did that as well. You're really working to solve the problem with the person, and somehow being permitted, actually, for once, to stay in and get it done. And that's, I think, really important.
I think in looking at quality issues, that it's really the discussion and the dialogue between the partners too. We have that monthly case management meeting where we're talking about our clients and our persons each month, but I think we learn each time from the different situations that we face. Each of them we're looking at as an individual, and a family is needing an individual service plan. So I think that's one area that we really take a look at quality.
I would
and
absolutely, focus on the collaboration, and I think a quality program is one where the people, clients, whoever, are satisfied with what they're getting and are appreciative of what they're getting and making benefit of what they're getting. And the fact that we're not seeing their names as frequently as we used to tells us that something's working right, and we're hearing just positive feedback from the actual people who are receiving the service.
Jackie, how do you think about quality?
I think for me, there are, of course, measure outcomes, there. Like we also look at, hospital readmission rate and things like that, number-wise. But I think, like day-to-day quality, I think I would really value the quality of life, that our participants, have, whether or not we're meeting, where they're at or what they're asking for. And I think that, at PACE, we're doing that, very well, and that's why we call them participant, because, they are there to participate, in the care plan, also. So I think that always bring them into the equation. It's not just us, providing the services, but it's also, them, on the receiver side, whether or not that is something that they really want.
Mm-hmm. Great. This question is specific for Jean and Martha. And I'll extrapolate a little bit on it. The question was about, does the larger Kaiser realize the success of this partnership? And are you seeing other Kaiser sites kind of taking on aspects of either this program in particular or other kinds of ways of doing this program? And in addition to that, are you seeing other health systems do partnerships with APS and other community-based organizations in order to close that care gap that we're seeing with some of these real high-risk individuals?
Yes.
Oh, yes. Okay, good. We're done. No.
As far as the bigger, we call it the big K, as far as the bigger Kaiser finding out about this program in new ways, all of a sudden, well, we started talking about readmissions, and we started talking about our special needs population, which is our acronym for the not dual diagnosis, dual eligible program. Similar, yes. And all of a sudden, there's renewed interest, and why aren't we doing more of this? And so, yes, there's absolutely more interest, and I have been approached by our continuum administrators, which is why I had actually reached out to Placer County, because our hospital is in Placer County, although we get a lot of Sacramento County residents. And then we were approached by Alameda County after APS was approached by Alameda County, and I think there was also earlier on, I did get a call from someone at Solano County. So the word is getting out there, and I do think that the time is right.
Mm-hmm. Mm-hmm.
Yep.
So kind of building on that theme, one of the things that is uniqueness across all the programs that have been presented here, and is that it speaks to a particular level of density in the state in terms of resource allocation, service providers, hospitals, health systems, community-based organizations. When you think about your programs, what do you see a translation of this kind of work in more rural counties, places where there's less density of service providers, greater just physical space between individuals and their health systems and or their families? How would you think about your model of care in those areas throughout the state? Given that, just so y'all know, the feds decided that California is not a rural state, right, that we don't have any rural areas of significance Yeah. I'm not sure that they've actually been to San Bernardino County, which I worked in for a number of years, or up in some of the north section. But in the event that we somehow are deemed as having some rural areas, how might you move forward on providing this kind of care model in those less dense areas?
Well, I would think for our program, working with APS and the hospital system, smaller counties, at least the communication that I've had with our smaller counties and their more rural client base, they know these people real well.
That's right.
And so I think this program is fabulous, would make way more sense than not do it there. So I think it would definitely translate.
And a smaller community of providers who actually know each other and don't have to go through that getting to know you process to even start
call
things.
Placer County sometimes and mention somebody. Oh yeah, I know Charlie.
Right.
It's like they know these people real well.
Right. For June and Jackie, thoughts on? I mean, there's been lots of discussions actually about rural PACE,
Yeah.
and your thoughts on that?
Actually, PACE has been very successful in bigger cities. So I understand that, there has been a demonstration project funded, by, different states about developing PACE in rural areas, in the country. I don't remember exactly which, city or county they were targeting at, but they were thinking about, modifying the PACE model, a little bit differently, rather than having like all the staff, hired for the program. They're actually, going to contract, out. And that's all I know. I'm not sure, what the outcome is. When I first heard about it, it was just, being implemented. But definitely there is a lot of interest.
Kind of the PACE without walls concept is one way I've heard people talk about it.
Yeah. And also there has been interest in, expanding PACE to other populations, like disabled, adults or even, kids.
Right. There's been a lot of talk on bringing in the developmentally disabled population into PACE and how that might benefit. June, thoughts on how the conception of your model might work in a less dense county or region?
Well, we still have the same kinds of leadership and coverage in most of those spaces. So it seems to me that with such a large population, there's 1.2 million duals. I don't know how many people are going into ACOs, but in California, ultimately they're working to get 1.2 million duals in. I mean, people are everywhere. We should draw on existing proven programs and modify and enhance them to meet the new reality. And there are many proven approaches and best practices. I was actually curious if you have a toolkit for your APS program, because if you go on the Administration on Aging website, or you go on the National Council on Aging Center for Healthy Aging website, you find toolkit after toolkit for evidence-based interventions. If yours isn't evidence-based, then maybe we should work towards taking it from, it is a starting point because it's a proven best practice. But we could move that up to evidence-based, which is another term medicine loves. So I think a lot of best practices exist in California across the country for rural or less densely populated areas, including the bridge model for transitions and a range of things. Home med still applies. It's really just figuring out a disciplined, effective way to target and to bring the right intervention for the right period of time to get a result and change a life and get better results for our society.
Super. So here's an awesomely controversial question, given the group that we have here in the audience. In your programs, or as you envision the movement forward of your programs, do the individuals who are providing what we would consider the social work component or intervention, do they need to have an MSW in order to be effective in your programs, or can we have someone who might be a BSW or someone who is training on the social work skill set but may not particularly have the degree, or we won't even go to the licensure piece itself, but so we'll just stick with the degree pathway. So thoughts on that?
Our family service workers don't have master's degrees, but are our paraprofessionals and an extremely important part of our program. Very definitely.
To be a medical social worker at Kaiser, you must have an MSW. 2/3 of my staff are licensed.
Okay.
And then at Unlock, currently among the 22 social workers that we have, I would say 20 of them, have MSWs. We have two or three social workers who are BSWs, but they've been with the agency for like 20, 30 years that, we grandfathered. But according to PACE regulation, somebody has to have an MSW. Yeah.
So those are model-driven. But if we're crafting an evolution and creating adaptations of proven models, then it seems to me if we look at least, again, I don't mean to be so parochial, but Los Angeles County has 374,000 duals and had 180,000 seniors and persons with disabilities, so meaning Medi-Cal only, no Medicare. So will there be enough MSWs to take all the high-risk targeted individuals? Or do they even need, there's masters in gerontology, there's other kinds of disciplines. But I think promotorists and community health workers and peer leaders for a lot of the evidence-based self-management programs, which are, Stanford research, there's a lot of opportunity to really change outcomes through self-care, which is driven by peer leadership, trained, overseen, facilitated, supported, and backed up. But it seems to me we're going to need to be having multiplier effects across broader workforces and learning how to screen for character values, capacity to listen, boundaries, the ability to have some boundaries, and to learn new skills and to mobilize those into disciplined settings where people can also document, which is going to be crucial, that then it's not the degree, although for certain roles I think we're crucial. We ought to take back the MSW leadership that we had when I was born.
Yeah, in APS we do hire only a master's degree for social work, but again, I like what you're saying in terms of a team approach too. If you're looking at a team approach, having different skills and knowledge on the team.
Medicine has the same challenge. They call it working to the max of their scope.
Yep.
So it makes sense for us to bring as many human beings into the care of each other as we can to bring their skills up, but for the more complex, you have very complex circumstances and a lot of legal overlay, a lot of liability issues.
And lots of unions.
And lots of unions. Well, there's another player we have to respect and consider. But I think that the ability to move outside those roles will be crucial if we're going to optimize outcomes, not just because the degree is important, but the non-degree has also got its skill base. The peer has a contribution to make that actually is made better than by the doctor or the nurse or us sometimes.
Great. So we'll just keep the controversial questions going. This is great. One of the trends that has occurred, at least on the healthcare side, is the concept of pay for performance, which is, the most outcomes-based perspective in terms of the work, that there is a target that one is seeking to hit, and that moving towards that target leads to an increased financial compensation for the individual or the team member who is responsible for helping achieve that outcome. So, do any of you foresee a time in which social worker pay will include this kind of pay for performance metric, either as at an individual level or as part of this system of care where social work is not only held up to this higher standard, but also has a benefit, kind of in the intrinsic benefit of receiving an additional support for all the high quality work that they do? Oh, I see the panel's stunned by the pay for performance metric.
We have to align incentives.
How do we? So I think that's the bigger question: is how do we align the incentives?
We have to align incentives. I heard a very interesting thing on the way to the airport this morning. about teacher pay. And they had done a study, and they said that they looked at people who just were, in line for regular salary as it goes, some who got a bonus, and some who had bonus at risk. It was a loss factor, I forget how they called it, but what they did, the best result of the three groups for kids learning, for the kids' performance in the classroom to be double and triple times better, was to give a bonus at the beginning of the year, let's say $4,000, and to tell the teacher at the end of the year if they hadn't achieved good results, they had to pay it back. Mm-hmm. And it really drove different behavior. So that was interesting to me. You would think it's but I guess it would be a little more motivating. You had to go out and put it on your credit card.
So are we bringing this to social work?
Well, I do think, money is a powerful force, and it should be used creatively. The question is, what will be the most responsible and inspiring and just use of these resources? What are we paying for, and how do we do it to get people's attention, keep their attention, and keep them jazzed up to really achieve great work in the face of great need?
Other thoughts on the panel?
What we do is that we have a built-in, compensation, system. I wouldn't call it a bonus, but it's all performance-based. And if you were able to achieve, to, let's say, the outstanding, level, then you'll get a bigger compensation, for the next year. And that's the standard that we go by. And if your performance is below what the expectation is, then you don't get any increment.
So it starts to move on that same kind of ledger that June was talking about, of really trying to drive people towards a broader set of outcomes of quality.
Right. To inspire good things, but what's outstanding?
That's a good question. What is the metric for that?
Right. Yeah. I mean, there are objective ways to measure that, and of course, there are, it can be very subjective, too. Mm-hmm. Yeah. So I'll just leave it at that.
Awesome.
We want to inspire. That's the main thing we want. Better.
So as we come to our last question for the panel, this is one of those that I think we've struggled with as a community since 1996 when the law was passed. Of how is it that we think through whether it's the reality or, frankly, in many ways, some of the mythology of HIPAA and what that really means in terms of information sharing when we're coming to these new models of care where there's a lot of different players who may not have historically even talked to each other or acknowledged each other's existence and are now really needing to bring their best capacities to the table in order to meet the needs of vulnerable older adults. How is it that you guys think about the HIPAA challenge, the HIPAA mythology, and maybe the need to create a different MOU structure or other kind of legal arrangements to ensure that the person's first and that there aren't any barriers for people really getting the care that they need, but also maintaining the appropriate confidentiality of people's information so that only that which is used is identified and disseminated. So how do you guys think about that?
I think within PACE, HIPAA is not that a big concern.
I was gonna say that's not fair. That's a cheater answer. You guys probably don't. You're all one set, right?
Because, we just
You're integrated.
Yeah, we integrated, and we just go across the hall to talk to another staff, on the same client.
Oh, we used to
So
do
we
that
don't
about
have
30
to-
years
Hey,
ago.
right.
So, but we do need to respect HIPAA, of course. When we go outside of unlock.
Right.
Yeah.
Right. So you still have those connectivities with other systems, and so it's about what's the appropriate respect kind of matrix to walk those lines. Mm-hmm, mm-hmm. But yeah, you're the vision. Okay, that's great. Others of you?
I think we utilize our monthly case staffings, the multidisciplinary team, in exchanging information. I know that when Jean comes, she doesn't usually bring us anything in writing. We exchange information verbally, but she doesn't show up and hand us anything. But I think just trying to respect our clients' confidentiality and only talking about things that need to be talked about to coordinate the care. And
Nobody in this room disagrees that privacy and confidentiality is of utmost importance, and we all want to work within the parameters of the law, but it also gets crazy sometimes. And that we have at Kaiser, we have compliance officers who are probably the most strict I've ever heard of in my life, and they hold us very, our feet to the fire on everything. And so we just have to get releases, or we do the APS reports, and we are as careful as we can to not put things in writing.
All right, June, you get the last word.
I just don't think the lawyers should overrule on this, because obviously we're trying to integrate the care of individuals, and the person's right to privacy should be absolutely protected, but their right to good quality care is balanced by the need to somehow think together and pool our wisdom and resources and get a great care plan and great results.
And that's really where we want to go. I think it's bringing it all together. Let's thank the panel one more time. Thank you very much.